This conference will now be recorded.
Excellent.
Good morning, everyone. Today's topic is going to be the pleural effusion. I think it's a kind of a revision class for you, for your examinations. It is important for you for theory as well as Viva practicals. So I think it's already December. I think you start preparing for your exams particularly. And regarding the pleural effusion, it is a basic thing you must have already learned from 3rd, 5th, and 7th semesters. What are its clinical characteristics, and it is also important for you in terms of theory as well. So it's very important for you to revise. It's a kind of a revision class for you for your Viva practical examinations. And if you have any confusion or if you have any doubts regarding this, I think please follow this class carefully, so that you might get what it is. And as you know, in Viva or in practical, this is the first question any external would ask you, or even internal, whatever examination may be. It's a basic thing. They start asking questions from this topic, and if you say this, you're basically, it's like a a pass mark examination kind of like thing. And if they're asking any top end questions and all that, if you fail to answer this, they'll bounce back to this one. So you have to answer this. Whatever question that is asked regarding the pleural effusion, you should be in a position to answer them. And this is a kind of a theory class kind of a like thing. And when you people come back to clinics and all that, we'll try to demonstrate it, and we'll try to even revise for you, as you're out of clinics for so long time now. So I think it's better to know the theory part of this pleural effusion and what are its clinical characteristics, and try to follow this one. As you know, the pleural effusion is defined as an abnormal accumulation of fluid in the pleural space, which is the space between the parietal and the visceral pleura. Usually the pleural space contains normally 0.3 ml per kg body weight of pleural fluid. There is a continuous circulation of this fluid, and lymphatic vessels can cope with several milliliters of extra fluid per 24 hours. It is a theory part of it. Fluid accumulates in the pleural cavity due to either altered hydrostatic and oncotic pressure or altered permeability of the pleura. Here the concept is actually the pleural space is between the parietal pleura and visceral pleura. That's correct. It's precisely more between the pleura and also the chest wall here. Whenever the parietal pleura comes to your mind, what it's done is it's because it have the capillaries. So the formed parietal fluid, it drains the capillaries present in the parietal pleura, drains the fluid, so that you don't have much of a pleural fluid lying in the pleural space. But I mean, draining from the capillaries, it all depends on the hydrostatic pressure and the oncotic pressures. You might have known what are they. Always the hydrostatic pressure in the capillaries or in the blood pressure. Whenever you hear the term hydrostatic pressure, you hear more in the cases of near the renal things, near the glomerulus, you hear the hydrostatic pressure. What is hydrostatic pressure means? Hydrostatic pressure always drives the fluid away from the capillaries or from the blood vessels. When a blood or a fluid is flowing in the capillary or in a blood vessel, hydrostatic pressure always takes the fluid away from the capillary, and oncotic pressure keeps the fluid in the blood vessel. So you have to remember that is the basic thing that happens here as well. So these are some definitions. You might have known parapneumonic effusion means synpneumonic effusion also it is termed. You know that. You have to answer that. What is parapneumonic effusion or synpneumonic effusion? When the pleural effusion is associated with the bacterial pneumonia, bronchiectasis, or lung abscess, you have to know that this is a parapneumonic or synpneumonic effusion. Sometimes these are other subsets of pleural effusion, which is sometimes the pleural effusion, the fluid present there can be loculated. I mean, because if it is present for so many time or something like that, So fluid anatomically confined and not freely flowing in the pleural space when there are adhesions between the visceral and the parietal pleura, which is called the loculated effusion. Subpulmonic effusion, which is the accumulation of fluid between the lung and the diaphragm, which gives the false impression of the elevated hemidiaphragm. Look, this is very important to diagnose. See here the X-ray of pleural effusion. What do you find there? It is a left-sided pleural effusion. What do you find there? It is blunting of the costophrenic angle. You know that. You know the term blunting of the costophrenic angle. You have to say what is the chest X-ray finding of pleural effusion. You have to say the blunting of costophrenic angle. There you can see there is a blunting here. This is a costophrenic angle, and you can't find that angle there. So here also there is a mildly developing pleural effusion on the right side as well, but on the left side you can characteristically and clearly see there is an obvious pleural effusion there. You have to identify them. If this is the chest X-ray that is given to you, you definitely have to identify what is the pleural effusion. This is the blunting of the. You might have known from the beginning. If you not, if you already know that, kindly revise these things. This is the parapneumonic effusion. Here you can clearly see that there is blunting of costophrenic angle in the right side. Left side there is a costophrenic angle that is there, which is present, but in the right side it is blunted. You can see the fluid, and above you can see that there are infiltrates. It's not clear like in here. You can compare it with the left side. Here there is infiltrated things. So there is a pleural effusion, and above there is a pneumonia as well. So it is called the parapneumonic effusion. As I said, it can be a bronchiectasis, it can be an abscess, or it can be a pneumonia. You know what is pneumonia means, which is the infection of the lung parenchyma. So as simple as that. So it is a loculated effusion. It's present like this. These two may not be much important, but you have to identify what is pleural effusion and you have to identify what is parapneumonic effusion. And this is the basic thing. This chest X-ray, you take the picture of it, or you shouldn't get that wrong in your examinations. I think this is a basic composition of what the pleural fluid actually contains. It usually a volume of 0.3 ml per kg. I have already said very minimal amount of fluid is present between the pleural spaces. It's not that it is absolutely absent fluid in those pleural spaces, but it's a kind of 0.3 ml per kg. Very minimal fluid is present, and these cells are present: lymphocytes, polymorphonuclear, which means neutrophils, protein 1 to 2 normal things. These are protein and DH. I will deal with it. I'll tell about that later. Yes, when it comes to lights criteria, you might have known that, but I'll already say. So what is the classification of the pleural effusion? How can that be classified? Pleural effusion is classified based on, it can be a lobar. The lobes. It can be an apical lobe, an interlobar, subpulmonic, mediastinal. It is not that important, because wherever it is present, you do, if it is a much of amount, you do thoracocensus. It is not that important, but the most important thing is you have to say what are the types of pleural effusion means. It is based on the mechanism and the type of pleural fluid. You have to say those are two types: transudative effusion and the exudative effusion. You must say this. What are the types of? This will be asked in every examination, viva or theory, whatever. Transudative and exudative. You must say that. Transudative effusion and exudative effusion. How was the transudative effusion is formed? It is based on a type of pleural fluid. If you do thoracocentesis, if you take the pleural fluid out, and you have to classify whether it is transudative or exudative. Whatever may be the pleural effusion, you have to take the fluid out and have to differentiate between transudative and exudative. Usually transudative effusion is formed, as I already said, it's an alteration in the hydrostatic and the oncotic pressure. In exudative things, it is an alteration in the pleural permeability. Is based on the mechanism and type of pleural fluid formed. I think these are all the other types. There can be pyogenic, there can be chylous fluid, there can be blood in the pleural space. Some pseudochylous hydrothorax means it when the pleural fluid occurs secondary to heart failure, urinothorax. These are all the types. For the theory sake, if a question is given, you have to mention all those things. This is pyogenic, chylous, hemothorax, pseudochylous hydrothorax, and urinothorax. You remember these names. So as I already said, the important thing that you have to say is whether it is a transudative effusion or an exudative effusion. What is I'll deal with the transudative pleural effusion now. So there is an alteration of hydrostatic and the oncotic pressure, oncotic factors that increase the formation or decrease the absorption of pleural fluid here. It can be because of the heart failure. I will give the examples of what are the transudative pleural effusion and exudative pleural effusion. Usually transudative pleural effusions occur when there is any organ failure. You have to say organ failure in the sense, in the heart failure you get the transudative pleural effusion. In liver failure or in cirrhosis or in renal failure or in nephrotic syndrome, whatever, any organ failure, usually you will get the transudative pleural effusion. Example, heart failure is the most common cause of pleural effusion. Left heart failure particularly, you have to say, if they ask you what is the one common cause of transudative pleural effusion, you have to say that is a heart failure. And second thing, cirrhosis and renal failure, you can also say them, but most important cause is the heart failure. Heart failure is the most common cause of transudative pleural effusion. You have to answer that if it is asked in Viva. This is a basic mechanism, as I already said. It's not much important to you, but please concentrate. Just know the basic thing: hydrostatic pressure and colloid osmotic pressure. You must have known this concept. Hydrostatic pressure takes away. You can see the blue arrow there. Hydrostatic pressure always takes the fluid away from the vessel. Colloid osmotic pressure always keeps the fluid in the vessel. So you also know that colloid osmotic pressure is because of the plasma proteins. That is, whatever might be the proteins present in the fluid, those proteins cause the colloid osmotic pressure. Those proteins are responsible for the colloid osmotic pressure, and these plasma proteins keep the fluid inside the blood vessel. When there is increased hydrostatic pressure, the fluid obviously goes out. When the fluid goes out of the vessel, it is termed as leakage. So that is the one thing. And in exudative, as I already said, it is a fluid and protein leakage and vasodilation. And here it is mostly because of the decreased colloid osmotic pressure, this transudate thing. So just remember, it's because of the osmotic pressure and the hydrostatic pressure. And just keep this diagram and keep the narrow hydrostatic pressure out and oncotic pressure in. If there is a theory question, it's for the theory point of view. As I already said, is a basic pathogenesis of the pleural effusion. So as I said, increased vascular permeability means, always increased vascular permeability means there is the propensity of the fluid to go out of the vessel. So which allows the migration of the inflammatory cells, neutrophils, lymphocytes, and eosinophils into the pleural space. The process is mediated by a number of cytokines such as interleukin-1. Interleukins is you also know, you might have known this as interleukins always contribute to the increased vascular permeability. These are all might be of not that important, but write the basic pathogenesis if it is given, and nobody going to ask you what is the basic pathogenesis in the Viva or practical. So just know about the increased vascular permeability, increased hydrostatic pressures, and exudative. You write what are the exudative. Any infection causes exudative pleural effusion, whatever might be that infection: pneumonia, bronchitis, pancreatitis, or tuberculosis. Tuberculosis is one of the important cause of exudative pleural effusion. As you know, tuberculosis is very, very common in India. So tuberculosis causes the pleural effusion, and that is exudative type. So you have to say one important cause of transudative heart failure, one important cause of exudative tuberculosis, as simple as that. And of course, what are the other things are which causes exudative pleural effusion? Or collagen vascular disease, which are called which are systemic lupus erythematosus, rheumatoid arthritis and polyarthritis, neoplasms, cancers, leukemias, and lymphomas. These three things you have to mention. Infective causes, what are the you mentioned whatever might be the infection, tuberculosis or pneumonia, whatever. Tuberculosis is the most important thing. Collagen vascular disease, rheumatoid arthritis is the most important thing. In rheumatoid arthritis, they ask what is the type of pleural effusion you see. You have to mention exudative. It's important for your Viva and exams as well, and also in the further competitive exams as well, but it is very important. You get the exudative pleural effusion in systemic lupus erythematosus, rheumatoid arthritis, and polyarthritis. And in cancers, neoplastic, which means cancers, in leukemias and lymphomas, whatever might be, in any malignancies, you get the exudative type of pleural effusion. And other causes are might be drugs causing the exudative pleural, bromocriptine, amidron, nitrofurantoin, isoniazid, and all that. Most important among them were amidron and bromocriptine. And post radiation, as I said, in cancers, you give radiation, and post radiation, you get the exudative type of pleural effusion and the traumatic. Transudate, renal cause. As I already said, nephrotic syndrome, cardiac cause, congestive cardiac failure. Congestive cardiac failure is very important cause of transudate pleural effusion. Hepatic cause, hepatic failure, nutritional protein energy malnutrition, and hypothyroidism. But congestive cardiac failure is an important cause of transudate pleural effusion, you must say that. And pyogenic, these are lung abscess, septicemia, rupture of esophagus. These all can cause exudative pleural effusion. These are all another causes of exudative pleural effusion actually. As I already said, the chylous effusion can be present. It can occur in the trauma to thoracic duct, tumor, tuberculosis, and lymphatic obstruction. Hemothorax in blunt in chest wall injuries and bleeding disorders, neoplasms, leukemias, lymphomas, mesothelial drugs, anticoagulants, and pulmonary infarction. This is pseudocylus and hydrothorax. How does the patient with pleural effusion present? You have to know that pleural effusion is not the single entity. You treat the pleural effusion not like that. You have the underlying causes for pleural effusion. You have to treat them. For example, pleural effusion is secondary to heart failure. You have to treat heart failure. If pleural effusion is secondary to cirrhosis, you have to treat cirrhosis. Of course, symptomatic treatment can be done by taking the fluid out, but you have to treat the underlying cause first. What is it? The underlying cause of effusion is usually dictates the symptoms, although the patient may be asymptomatic sometimes. The pleural inflammation, abnormal pulmonary mechanics, and worsened alveolar gas exchange produce symptoms and signs of the disease. What are the symptoms? Inflammation of the parietal pleura, as I said, leads to pain in the locally involved areas or the referred distributions, but pain can occur in pleural effusion, especially in pyogenic effusions like in empyema. It is usually painful. So pain is one of the thing. Dyspnea is the frequent. You have to say what are the symptoms. You have to say dyspnea is frequent and may be present and out of proportion to the size of the effusion. Dyspnea is important thing. Cough can occur. So this is very important. This slide you have to remember. You might have known, you might have hearing since the last 2 years in the medicine postings. If you have any confusion, just remember them. If you already know that, kindly revise and try to differentiate it from what are the other common causes, pneumothorax or hydropneumothorax, something. But you know the basic characteristic features. This is very important for you. You can't afford to say wrong these things. You just can't afford. It's a basic thing. As I already said, what are the inspectory findings in pleural effusion? If someone asks you that question, just say that absent or diminished movements of the affected side or the fullness of the chest with bulging intercostal spaces. So in palpation, diminished breath sounds over the site of effusion and decreased or absent tactile firmitus. Vocal firmitus or tactile firmitus, it is decreased or absent in pleural effusion. This must be answered. And of course, you know that in percussion, there is stony dullness to percussion. So in percussion, the percussion note is stony dull. You have to mention the dullness occurs even in consolidation, that is in pneumonia, but here the stony dullness in pleural effusion occurs. So you have to say that. And in palpation, decreased breath sounds because the fluids are the bad conductors of sound. So there is a decreased breath sounds, diminished breath sounds over the site of effusion. And there is a decreased or absent tactile firmitus. In percussion, it is a stony dullness to the percussion, and in auscultation, as the fluid is a bad conductor of sound, so there are absent breath sounds over the effusion. Vocal resonance is the auscultatory component of vocal firmitus, that is tactile firmitus. So You can't say that one is increased and one decreased. If tactile film test in any condition, if tactile film test decrease, vocal resonance also decreases. Remember that. It is just vocal resonance is the auscultatory component of palpatory tactile fremitus. You know what are the things that is coming in palpation, what are the things that is coming in percussion, and what are the things that come in auscultation. Just simple. Stony dullness in percussion is stony. You just have to say that. You can't afford to say that wrong. In auscultation, the absence of breath sounds or the effusion, vocal resonance is absent, and the signs of pneumonia, something if the pneumonia is present, sometimes you can get the bronchial breathing as well. But bronchial breathing is, the sign of pneumonia, not pleural effusion. I just written it because of when there is coexisting thing. But as I am repeating again because it's most important to you. What are the palpatory findings of pleural effusion? If someone asks this, first and foremost thing you have to say is diminished breath sounds over the site of effusion. As simple as that, because the fluids are the bad conductors of the sound. And there is decreased or absent tactile fremitus. Stony dullness in percussion, that's the thing, and absence of breath sounds over the effusion. And the vocal resonance are absent. Vocal resonance absent. So just remember that. So other investigations, total and differential counts are usually increased because of the pneumonia, acute phase reactants of white cell, total CRP, propane, distinguish bacterial from viral causes. These are all kind of investigations you can radiological chest X-ray PA view, then in erect position. First and foremost, what are the investigations in chest X-ray PA view? You have to say that. In an erect position is diagnose 300 ml of fluid is needed to diagnose pleural effusion. So usually pleural effusion can occur, we can call even if it is more than 150 ml of fluid, as I already said, 0.3 ml per kg. That means if it is a 60 kg person, for example, it's very less indeed. You just have the 15 ml altogether. But even if it is more than 20 or 25 ml, you can term it as pleural effusion. But in chest X-ray can find out if there is a minimum of 300 ml of fluid is present in the only chest X-ray can find out when there is 300 ml of fluid of pleural effusion. If there is even 50 ml of fluid, can be demonstrated radiologically in lateral decubitus. I'm repeating it again. In lateral decubitus view, even 50 ml of fluid can be detected. But if it is more than 300 ml of fluid, so normal erect X-ray, 300 ml of fluid is needed to know whether there is pleural effusion or not. Findings: obliteration of cardiophrenic, as I already mentioned, cardiophrenic and claustrophrenic angles. You might have to say the blunting of the claustrophrenic angles or the obliteration of claustrophrenic angles. Sometimes rock-related effusions, the additions can develop there. And subpulmonic effusion, collection of fluid below the diaphragm will lead to elevation of diaphragm confirmed by X-ray in the lateral decubitus. Lateral decubitus on side of effusion will show a shift in the fluid level. Tracheal and mediastinal shifts are seen in massive effusion. As already shown that here, you can see that the blunting of the claustrophrenic angle. You can see the claustrophrenic angle is normal here, but here it is blunted, obliterated. So if you're not sure with the with the chest X-ray, then you can go for chest ultrasound. It is useful in differentiating between loculated effusion and tumors, etc. And you can go even for chest CT scan. It's helpful in some. Sometimes when the pleural fluid, when there is a massive pleural effusion, you have to do pleural fluid aspiration. Sometimes when 200 ml or something fluid gets accumulated, the patient will feel breathless. There will be shortness of breath. Then we have to do therapeutically, not for diagnostic sake. You have to do therapeutic pleural fluid aspiration. Aspiration means taking the pleural fluid out, which is the term thoracocentesis. It is done in massive pleural effusions. Thoracocentesis can be therapeutic or diagnostic. Therapeutic means we are helping the patient with this. We are treating the patient. Diagnosis means we are taking the fluid out to know whether it is transudative or exudative. So pleural fluid aspiration, the process is called thoracocentesis. You have to know this. You have to answer this. If anyone asks a question, when diagnosis, as I said, pleural fluid aspiration can be diagnostic or therapeutic. If it is diagnostic, it helps to differentiate between exudates and transudates. In therapeutic, as I already said, when there is a massive collection, when the question is asked, when will you do a therapeutic thoracocentesis? You have to know what is thoracocentesis means then. Thoracocentesis means pleural fluid aspiration. So when will you do therapeutically? Therapeutically means we are treating the patient. So therapeutic thoracocentesis is done in massive collection or rapid collection of pleural fluid. And sometimes the pleural fluid collects rapidly, you have to do that. In severe respiratory distress, when the respiratory rate is up, when the patient is feeling severe breathlessness, you have to do therapeutic. And so, as you know, in massive pleural effusions, there is a mediastinal shift of trachea. So if that is found out in X-ray or in your clinical examination, you have to do that. And when there is suspected empyema, but you have to say, and there is massive collection or rapid collection of pleural fluid, you have to do therapeutic thoracocentesis. As I already said, the chylus purulent and blood stain. As you can see, it is a straw colored. Usually it is seen in tuberculosis blood stain. Here you can find that chylus, usually white. So what are the differences between the transudates and exudates? The basic thing you have to remember is in transudate, the protein level is less. In exudates, the protein level is more. You just remember that basic thing. Other things you might remember, might not remember, but this protein component you have to remember. Usually in transudates, the protein is less. That is less than 3 grams per 100 ml. In exudates, it is more than 3 grams per 100 ml. Other things it will come in lights criteria, might not have to remember, but this thing you have to remember for the basic concept. So this is lights criteria. When anyone asks in theory question say randomly about pleural effusion, if you say about the lights criteria, it will be half done actually regarding the pleural effusion. If you mention the name itself, the lights criteria for pleural effusion. So what is lights criteria here? At least one of the following criteria should be satisfied to identify exit. What is basically for lights criteria for pleural effusion? Lights criteria of pleural effusion is used to differentiate between exudate and transudate. You have to remember that this name you just have to get imprinted in your mind. It's a basic question. I think even 90 to 95% of the students will be asked this question. What is the criteria used to differentiate the pleural effusions? You have to say the lights criteria is used to differentiate it between between the exudative and transudative effusion. So what is that? When the pleural fluid to serum total protein more than 0.5. So you have to remember it is differentiating between the pleural fluid protein, as I already mentioned. When the pleural fluid protein ratio to serum total protein, I mean it's the ratio of pleural fluid protein and the serum total protein. If it is more than 0.5, it's one criteria is satisfied. Second thing, it is a ratio of pleural fluid LDH to serum LDH. If it is more than 0.6, the second criteria is satisfied. And the pleural fluid LDH more than 2/3 of the serum LDH. It is just the extension of the second one. So any two, at least one of the following criteria should be met. Preferably two, but at least one of these three. You have to by heart it or whatever, but try to understand. It will be very easy for you. It is basically the ratio of pleural protein to serum protein. Serum means blood protein. You have the protein in your blood, right? You have the protein in your pleural fluid, right? So it is basically the ratio of pleural fluid protein by blood protein or serum protein. As simple as that. It has to be more than 0.5. If it has to be exudative, as I already said, the proteins are more in exudative. So when the pleural fluid protein to serum total protein ratio is more than 0.5 as an exudate, in the pleural fluid to serum LDH ratio is more than 0.6. It's an exudate thing. If the pleural fluid LDH is more than 2/3 of the serum LDH, So remember the Light's criteria for pleural effusion. Try to by heart this, remember this as much as possible. Very basic things. You know, what's the problem with you? You're dealing 4 subjects now. When you go to the exam, I know that the 4th year is the toughest among all the years. You know, you are dealing all the massive subjects, all the very important subjects for your career. So each subject has its own post graduation, you know that. So just keep the basics right of with every subject, whatever might be the subject. In medicine there will be some topics from the for the viva and for the theory exam. This is one among them. You can't afford to go wrong. And second thing, uh, you just as I already mentioned, when you keep the basics right in each subject, then you can build on that easily. So as I already said, it's a light criteria for pleural effusion. That there are also topics like pneumothorax, hydropneumothorax, and all that. I'll try to explain it later and differentiate between those things. In hydropneumothorax, you get the suction splash and the shifting dullness. Also in lung there is a term called shifting dullness and succussion splash. It is for hydropneumothorax. How to, when somebody asks the question how to differentiate it between the pleural effusion and hydropneumothorax, you have to say that in hydropneumothorax there will be succussion splash, there will be shifting dullness, and there will also the water fluid level is right there. I will say that earlier, but you keep these basics right, and you'll just be able to make it. And also try to it's just not the matter of getting enough marks to get through to the house urgency or further. The rules are changing every day. Every year the rules are getting tougher and tougher for our doctors. So it's very important, be wise enough to score more marks now itself. I think just keep examination in mind. Now it will be, it is coming near, it's on the cards now actually. So try to keep the basics right with every subject first of all, as it is already December. So you be careful. Whatever we are dealing are the simple basic things. You just revise it and just keep them updated, so that when you come here, when you are on when you're on for the examinations, try to score more marks here. We don't know, no, these marks can be considered for for competitive exams as well. We don't know, so just be wise enough to score more marks in your examinations now itself. So coming to the topic again, so exudative Light's criteria: the pleural fluid to serum total protein ratio more than 0.5, pleural fluid to serum LDH ratio more than 0.6, and pleural fluid LDH more than 2/3 of the serum LDH. If none of these criteria is met, then it is transudative effusion. Pleural fluid appearance. Most transudates are clear, straw-colored, non-viscid, and without odor. Red tinged pleural effusions indicate the presence of blood. You know that. When there is a bloody pleural fluid, if the blood is due to thoracocentesis, the degree of discoloration should clear the aspiration. The bloody pleural fluid usually indicates the presence of malignancy. This is an important question. When do you find the bloody pleural effusion? It is in the presence of malignancy or pulmonary embolism or trauma. So these things are very important. In malignancy, pulmonary embolism and trauma, you find the bloody pleural effusion. Hemothorax. The presence of gross blood should lead to the measurement of pleural fluid hematocrit. Hemothorax is defined as pleural fluid to blood hematocrit ratio of more than 0.5. Very important. You have to remember that. Pleural fluid to blood hematocrit ratio more than 0.5. And chest tube drainage should be considered. Eosinophilia is suggestive of air or blood in the pleural space. If air or blood is not present in the pleural space, consideration should be given to fungal and the parasitic infection, drug-induced disease, pulmonary embolism. Lymphocytosis. More than 50% of the total nucleated cell count is malignancy or tuberculosis. Whenever you find excess lymphocytes in the pleural fluid, it is suggestive of tuberculosis or malignancy, which is important. Tuberculosis is the most important. You already know that the lymphocytes are more in tuberculosis. So any mesothelioma argues against the diagnosis of tuberculosis. Plasma cells suggest a diagnosis of multiple myeloma. So glucose concentration. A glucose concentration of less than 60 milligram per deciliter is probably due to tuberculosis, malignancy, rheumatoid arthritis, or paranemonic effusion. glucose concentration might not be that important for you, but protein, as I already said, protein is very important for you. So usually you can remember these things for your competitive exams or whatever. A glucose concentration of less than 60 milligram per dl is probably due to tuberculosis, malignancy, rheumatoid arthritis, and a parapneumonic effusion. When you find these things, usually those are all exudative effusions: tuberculosis, malignancy, rheumatoid arthritis. So you can say that in exudative effusion, the glucose concentration is less and protein concentration is more. So the pH. When do you find a pH of less than 7.3 is seen? So pleural fluid with a low pH. You can see that in empyema, tuberculosis, malignancy, collagen, and esophageal rupture. As I already said, if the low pH is also exudative effusions. You know that in exudative effusions there are low pH empyema, tuberculosis, malignancy, collagen vascular, and esophageal rupture. Most important things are malignancy, tuberculosis, and collagen vascular disease. That is a low pH. And elevation of amylase suggests that the patient has pancreatitis. You always know in pancreatitis there is elevation of lipase and amylase. So if there is an elevation of amylase, you can see that the pancreatitis, malignancy, or esophageal rupture. Malignancy and esophageal rupture have a salivary amylase elevations and not pancreatic. So now, if after the pleural fluid is centrifuged, if the supernatant clears cloudiness, it's not that important. But you need to kindly, you can concentrate on this line. Elevation of triglycerides suggests that chylothorax is present. So in chylothorax, basically there is an elevation of triglycerides, usually due to disruption of the thoracic duct from a surgery or the malignancy. So cytology, the cell things regarding in the pleural effusion. Cytology is positive in approximately 60% of the malignant effusions. The volume of pleural fluid analyzed does not impact the yield of the cytological diagnosis. Repeat thoropocensis increases the diagnostic yield. As I already said, pneumothorax sometimes it's very rare actually. In obstructive uropathy, it can occur, but it's not that important actually. As I already said, what are the other investigations? You can do pleural amylase to differentiate whether it is pancreatitis or not. Pleural fluid rheumatoid factor in rheumatoid arthritis, in all that polymerase chain reaction in tuberculosis, first bacilli, all that. These are not that much important to you. If you suspect a particular disease, if you suspect it is an SL, it's all based on the diagnostic findings. You can do serum complement ANA levels. You can send them, but yeah, it all depends on the type of disease. That's pleural biopsy. Sometimes pleural biopsy is needed, so it can be done at maximum dullness or percussion or whatever. It's most helpful in evaluating for tuberculosis. Pleural biopsy. How do you manage? Usually the patient present with shortness of breath, so oxygen saturations may go down. So supportive treatment, oxygen, you have to oxygenate the patient if the SpO2 is less than 92%. And antibiotics, if it is an infective cause. I already said infective causes are the most common cause of exudative effusions. All the infections like tuberculosis, pneumonia, bronchiectasis, whatever, they lead to exudative effusions. And if you find that, if you do thoropocensis, and if you find that the Light's criteria is supportive of exudative effusion, then you have to initiate the IV antibiotics for that particular infection. And analgesics and antibiotics, because I already said, pain can be present. Sometimes the fever can be present. If there is a pneumonia, there can be fever, there can be pain, and as I already said, just radiography and ultrasound can be done. What are the initial antibiotics that you use for if pleural effusion is secondary to community acquired pneumonia? Then you can use the cephalosporins. Cefuroxime is cephalosporin. Coamoxiclav, it is basically amoxicillin and clavulanate is a penicillin group. Usually you can use cephalosporins and penicillins. You can say that. In hospital acquired pneumonia, of course, you have to the higher things. You go for the higher things. And if it is tuberculosis, you know that you have to give the tuberculosis treatment. And sometimes if there are additions, you can give steroids for brief period, but those are not never the treatment of choice. In congestive cardiac failure, you have to treat, as I already said, you have to treat the underlying cause, that is congestive cardiac failure, with diuretics and anti-heart failure medications. Then the pleural fluid will subside itself. Sometimes the surgical pleural fluid aspiration, how to do that? This is the way the patient has to sit so that the fluid accumulates due to gravity here, and you can take the fluid from here. Is done by the white bore needle. The fluid is thick and cannot be drained by needle. Then intercostal drainage at the most dependent part must be done. As I already showed, what is a tube thoracostomy, and it has to be done when there is a pneumothorax, when there is loculated. When the question is asked, when do you do tube thoracostomy for pleural effusion? Then you have to say it is a pneumothorax, pleural fluid alloculation, the recurrent pleural effusion, the malignancy, effusion filling more than half the hemothorax, air fluid level, hydro or pneumothorax, pus, and all that. As you can see, the underwater seal bag, you have to say this for pneumothorax. You must have underwater seal bag is used to one valve mechanism. You can use that in pneumothorax actually. These are some things which are how the tube is inserted and all. Sometimes video assisted thoracoscopy can be done when there is loculated effusions and all that. When you can't come to a conclusion, when you can't come to a diagnosis, then you can do thoracoscopy using the video. Thank you. As I already said, it's very important to know this entity called pleural effusion. You can go through Davidson or you can go through Harrison, whatever, or even if you in a clinical book, be sure with this topic, pleural effusion. Lights criteria, differentiate, what are the take home points are the lights criteria is very important. Differentiating between the exudative and transudative are the minimum basic things a normal fourth year student must answer. Remember them, and from now I'm going to deal with exam topics, whether it is a practical or in a theory, so that you can be well versed with it, and also advise you to start preparing for the exam now. This time's running out, so I think it's better start preparing and take individual subject, have a plan for individual subject. What are the basic things for practical and viva, divide them and start preparing for them. As I already said, be wise enough to score more marks now itself. Don't rely on any other thing, just try to score more marks. It's not just about getting through now, you have to score more marks. If you have any doubts, you can contact me, whatever, but be sure for the medicine practical, pleural effusion, hydropneumothorax, hopefully I will deal with it in next class and differentiate that, pneumothorax and pneumonia. You have to know these four things, how their x-rays look like. You can Google it and you can see. You got to have an idea about their theory as well. A theory, these four topics for theory and practical purpose as well, it is very important. And try to now get a plan for each and individual subject, and just start preparing now itself. Keep a book, write down the topics and just tick them off. You have to revise them, keep them for 2 times, and you just have to keep planning now. You just can't leave to the end, and it will be very tough for you. I'm telling you, it will be very tough for you when you come to the final days, dealing 4 subjects on a trot: surgery, medicine, gynec, and pediatrics. You are in a very crucial time now. You haven't attended the clinics because of the COVID, so you can clinically you can improve that in your house surgeon period. But regarding the theory part, medicine, you just deal with the basics, whatever the topics I have told you, and important questions I'm going to deal with you. So I think be careful enough and be little more careful now from now on. It's already December now. I'm just advising, try to score more marks for your future as well. We never know, the rules are changing sometime. Some down the line, MBBS marks might be taken into account for your post graduation as well. We don't know, we never know. So be wise enough to score more marks now. Start preparing up for your future as well. Thank you.